A diabetic patient came in for wound care. He left without a limb. Here's what happened and what every podiatrist needs to know. The patient was a 56-year-old carpenter with diabetes and vascular compromise. He presented with a plantar midfoot ulcer caused by bony prominence from Charcot deformity. This was already a high-risk case from the start. The insured's initial assessment flagged osteomyelitis and infection, but no additional cultures, labs, or imaging were ordered at that time. The left foot was offloaded with a CAM walker, and the patient was prescribed antibiotics. At follow-up visits, the insured noted the patient was on his foot frequently. Over 10 months, the ulcer grew larger and showed signs of possible infection. X-rays diagnosed Charcot deformity of the subtalar joint with the calcaneus sliding laterally off the talus. Repeat X-rays confirmed the deformity had worsened and required surgery. At the final visit, the joints were crepitous and the ulcer had grown further. The insured directed the patient to go to the hospital for limb salvage and to notify the ER that bone was exposed. The patient waited 13 days before going. A CT scan revealed Charcot arthropathy with deep soft tissue infection. There was concern for osteomyelitis and septic arthritis. The patient ultimately underwent a below-knee amputation. 3 allegations were brought against the insured: failure to accurately diagnose the extent of the patient's osteomyelitis, failure to make the patient non-weight-bearing and restrict activity, failure to obtain regular cultures. The amputation was likely tied to Charcot deformity, diabetes, and the patient's own non-compliance. But those factors alone were not enough to shield the defense. There were significant concerns about deviations from the standard of care and the lack of timely intervention. The prosecution could argue the signs of infection called for more thorough testing and timely specialist consultations. While the patient's 13-day delay could have supported the defense, the insured never documented how that delay could impact the patient's outcome. Without a clear timeline or documented progression of the infection, a jury would have difficulty determining whether the delay contributed to the amputation or whether the amputation was inevitable. This case was settled. There are 3 actions every podiatrist should take when treating Charcot patients. First, document a treatment plan. Include the patient's present condition and monitor for signs of infection. Charcot patients need clear expectations about disease progression, how adherence can preserve the limb, and what non-compliance could cost them. Second, utilize appropriate referrals for high-risk patients. Bringing in specialists early means the patient and family hear consistent warnings from multiple providers. This reduces claims that the patient was unaware of outcomes like amputation, sepsis, or death. Third, always conduct an informed consent discussion and document it. Explain the risks of non-compliance. Record the conversation in the patient's medical record. Consider involving family members so adverse outcomes are not a surprise to anyone. In this case, the medical records lack clear instructions and progression notes. That gap made it nearly impossible to build a strong defense. Download your copy of this case study and access additional risk management resources now. And for more information about Charcot deformity and diabetic wound care malpractice, visit our website.